Good afternoon, everyone. I want to welcome you to our 18th HIV Tele-Echo session. Today, as a facilitator, my name is Dr. Nyakulira Kandiwo, and the topic that we'll be discussing will be HIV testing models. Our focus will be more on HIV index testing as well as HIV self-testing. So we are going to have a didactic presentation, and our presenter for today will be Dr. Maureen Simwenda from Solwezi. Then we'll have Lundazi sharing some of their good practices and experiences on HIV index testing. And later on, we'll have a case presentation from Chile that will be presented by Kelvin, who is a clinical officer, ART prescriber. So welcome you all to this session. You can just wave if you can hear me. Thank you very much. So back here at the Hub, we have different subject matter experts who will be helping us discuss today's topic. And then we will also, among the subject matter experts, we have Dr. Sivile, we have Mr. Nkwemu, and we also have David. We have other people from Pediatric Center of Excellency and the Adult Center of Excellency that will also be able to give their input on the case. So before we proceed, I would just love to give a recap of what we discussed last week. So last week we were looking at hepatitis B infection in Zambia, and our presenter was Dr. Viniko, who has vast experience in managing patients with hepatitis B infection. So among the things we discussed was the burden of hepatitis B infection in Zambia, and we heard from the Zambia report that our prevalence is somewhere between 5 to 7%. We also discussed the modes of transmission of hepatitis B, which in children, we discussed that mostly occurs during delivery. And for adults, it can be sexual, or for health workers, we learned about the risk of contracting hepatitis B through needle stick injuries. And we learned that the risk is 30% for hepatitis B compared to 0.3% for HIV. However, good news, we also learned that hepatitis B is preventable, and we're urged as healthcare workers to get screened for hepatitis B and to get vaccinated. So without further ado, I think at this point, we are going to proceed and start with our didactic presentation. So I'll ask Dr. Maureen Simwenda to kindly briefly introduce yourself and share the slides. Unmute her.
Okay, thank you. Good afternoon, everyone, and greetings from Solwezi. I'm Dr. Maureen Simwenda. I'm the Director of Clinical Health Services at JSI on the USAID SAFE project. I'm actually based in Lusaka, but at the moment I'm in Solwezi. I sit with the MOH, and we work very closely with the MOH, the team in Lusaka, especially. I sit with the team on the National HIV Technical Working Group, and also sit on the various National Technical Working Group sub-committees. So today, I think we should all be excited because with HIV self-testing and index testing, we are actually getting smarter at the way we are doing our work in HIV testing in order to identify the remaining people that we need to put on ART. So I'll share the presentation now.
Okay.
So I can't share from here. I think, can you share for me? Okay.
Okay, so we are going to share the slides from the Hub.
Okay.
So you can go ahead with the presentation. Okay, you can go ahead with the presentation, Dr. Simwenda.
Okay, all right, great. So maybe you can go to the next slide. Okay, so you can go to the next slide. Okay, so the objectives of today's presentation, we are going to look at the background and explain the background. We'll discuss the new modalities of HIV testing, which index testing and HIV self-testing. And then we will go on later on and apply the concepts of index and HIV Soft Testing after the presentations, of course, in our facilities. Slide. So move to the next slide. Okay, so the background is that as Zambia, we all know that we are still one of the countries that have a high HIV burden. Currently, there are about 1.2 million people in Zambia that are living with HIV. So according to the Zambia 2016 report, we still have 32.7% that are unidentified, that is people that are living with HIV in Zambia. So we do have free HIV counseling and testing services across the country, and yet we still have these gaps, which are mainly attributed to the setups, the different setups that we have at facility level, also lack of privacy and some stigma issues that we still have. So the Ministry of Health has adopted the recommendations from WHO on HIV testing and index testing in order to reduce the gaps that are existing in our current data. So when you look at this slide, I'm just trying to show you the unmet need in both the males and females, and that we do still have a gap in men still not being reached, and also in females aged 15 to 34 years. Next slide, please. Okay, so when you look at what happened just in the first quarter of FY19, this is on the PEPFAR data that we have. We did actually do a lot of index testing to reach out to those populations that are unmet. So in FY19, in the first quarter, we actually did test a lot of clients, and we managed to index about 65,000. I know that some of you may not understand what I mean by indexing, but we'll discuss that later. So just from the indexing data, we managed to identify about 10,405 clients, and that were put on ART. And the yield, that is the new positives or the positivity rate with index testing, was about 16%. So with this data, again, what I would like you to appreciate from this data is that when we look at index testing versus VCT, we are actually testing a lot of clients through VCT, but the yield with VCT is at 4%. So when you compare it to index testing, we only identified about 14% of clients that were positive from all the clients that were identified to be positive, but the yield is much higher than the clients that were identified through VCT. So the yield through index testing is around 10%. So we are testing more using VCT, but identifying less clients. But when we test using index testing, we actually test less, but identify more clients. Next slide. Okay, so again, on the self-testing slide that we have here, this slide just shows how many kits were distributed in the first quarter of FY19. That is from the PEPFAR data, and this is from October 2018 to December 2018. So we distributed around 33,000 test kits. So from the data that is here, we are again reaching out, more men. We are reaching out more men than female. We're identifying more females than men. And the other thing that maybe has come out of this data is that we are again identifying, looking at people that really have needs for HIV testing. So on this chart, what we can see is that the women are between 15 to 34 are still not being reached, and then also the men are still not being reached. So we need smarter ways of reaching to these men, and also to the other populations that still need a lot of testing in their populations. So the next slide just talks about how we have all these guidance in the current guidelines. So if you look at the details of the 2018 guidelines, we do have guidance on HIV self-testing, and also guidance on index testing. The next slide, please. Okay, next slide. Okay, so what is, yeah.
So we now have our first polling question before we proceed to talk about HIV self-testing. So before I launch the poll, just to quickly read through the question. The question is, the following statements are true about HIV self-testing, except, so we have three options there. A, HIV self-testing is a process in which a person collects his blood, his or her own oral fluid or blood, then performs an HIV rapid test and interprets the results. And then B, an HIV self-test result is not affected by the window period. And option C, a reactive self-test must be followed by a confirmatory test at the clinic by a trained provider. So I will launch the poll and then we can vote. Okay, so I'm launching the poll now. Okay, we have some responses coming in. The answers are split so far across A, B, and C. Okay, so the majority are going for C. The following statements are true about HIV self-testing except. Okay, so 60% think the answer is C. Give a few more seconds for people to vote before we end the poll. Okay, I'm going to end the poll now. So you can proceed, Dr. Simwenda. We'll discuss the answers later.
Okay, so what is HIV self-testing? So HIV self-testing is a process whereby a client who is interested in knowing their HIV status collects a sample of their either blood or oral fluid and performs a test and then interprets the results on their own. And this, in an ideal situation, is done in a private setting where the client is just on their own or with someone that they trust. So HIV self-testing is not a confirmatory test, needs a confirmatory test. It's a screening test. So it does not provide an HIV positive diagnosis. So if a patient tests positive with an HIV self-test kit, they still need further testing at the facility. So they will still need to be tested using a determined test and then also confirmation by an SD bioline test. Next slide. Okay, so like I mentioned earlier, we still have a gap on the first 90. There's still that 32% that still need to be identified. So HIV self-testing actually has the potential to reduce this gap. So there are clients that are not comfortable with coming back to the facilities to actually, have a test done on themselves. So they would actually prefer having, to test in a private, in private, and maybe testing on their own using an HIV self-test kit. And then it provides a little bit more, confidentiality as compared to testing at the facility, especially where there are challenges with privacy. So there are a lot of, types of HIV self-testing. There is the blood-based and also the oral-based, tests. So the current kits that we have in Zambia are actually the oral fluid-based testing. So the 5 components of HIV testing, the 5 C's, still actually apply on HIV self-tests. We need to still get consent from the clients before we distribute the test. They still need for confidentiality, and then the correct results should also be communicated. There is still room for counseling and educating the clients, and then the connection, that is the linkage to the various services that are available after HIV self-testing, depending on the outcome. So this is just a slide to show the actual kits that we have in Zambia. So you have the oral quick that is available in Zambia in almost all our facilities, especially the ART facilities. So on your upper left there, you have the kit. There's a gadget that it comes with, and then it comes with a small container that has the buffer. And then the manufacturer has actually translated the guidance on the test. So the instructions come in different languages. In Zambia, they come in English, Tonga, Bemba, and Nyanja. So we will try and have the manufacturer actually translate into the other languages like Lozi, and also the other languages on the Northwestern province. We can also see a positive and a negative test on the previous slide. So there are different types of distribution models that we have using HIV self-testing. So we can distribute through the facility and also through the community-based channels. Okay. So on the facility-based channels, we distribute through the various departments at the facilities, through the MCH, the OPD, and the ART clinics. And then in community-based distribution, we distribute through activities that we have in the community. For example, when there's the national testing, then we can actually distribute HIV self-testing. And then we also have what we call the primary and secondary distribution. So in primary distribution, you actually distribute the kit to the individual that is going to perform the test on themselves. And with secondary distribution, especially this is working in the MCH, is whereby you distribute an HIV self-test kit to a client that will hand it over probably to maybe a partner, in this case, maybe a husband who is not found at the facility. But with secondary distribution, we are limiting the HIV kits to just one person and not more than one person. So this is, I'm unable to play this video because I think the slides that the Lusaka team have is in PDF. But if time allows, I can play this video later on after the presentation. Okay, can go to the next slide. So this slide is in PDF and I'm unable to play the demonstration video. Okay, so after testing using an HIV self-test kit, there is still, the clients still need to be linked to the appropriate services. So we need to emphasize that there's still a window period for those that are found to be HIV negative. And then we need to link the positive clients and the negative clients to the appropriate services. So in this case, the positive clients should be linked to treatment and the negative clients should be linked to prevention services such as PrEP, condom distribution, and VMMC. In the pilots that were done, there were various possible harms that were identified, but these were minimal. So in the distribution of HIV self-test kits, there are these possible harms that can be encountered and we should be aware of, and these include gender-based violence, marital issues, especially if at all someone is coerced to actually use an HIV self-test kit. Depression was also reported. There were some people that attempted suicide and self-harm, but again, I should mention that these were minimal and not really significant. And some, clients were rejected and, isolated after, using an HIV Soft Test kit. And then there was also coercion in some relationships whereby someone gets an HIV Soft Test kit and forces the partner to test. So we'll go on now and talk about index testing.
Okay, so before we proceed, we have our second polling question, and this one is on index testing. So the question reads, choose a statement which correctly describes what index testing is about. And the options are A, an index client is a person who has had HIV exposure regardless of the HIV status. B, in index testing, all household members and relatives of an HIV positive client are tested for HIV. And option C, the goal of index testing is to break the chain of HIV transmission by offering HTS to persons who have been exposed to HIV. So I am going to launch the poll, and we can vote. We can pick an option. Hub, what are we going for? Hub? Okay. Okay. So far, we have 11 facilities, 12 that have voted, and 86% think the answer is C. Okay, we have 20 facilities. We have a few more seconds to vote before I end the poll. Okay, I am going to end the poll now. So far, we have 91% going for C. We can proceed with the presentation.
Okay. So we'll discuss index testing. The first thing that I'd like to mention is that when you're talking about index testing, we have to be aware that now we're talking about very sensitive matters, and we need to really be trained in index testing before we actually offer these services. So who is an index client? So an index client is an individual who is a newly diagnosed HIV positive client, and who is enrolled in HIV treatment services. And then with index testing, there is a voluntary, it is a voluntary process whereby a client is asked, an HIV positive client is asked to list all their sexual partners or any injecting drug partners within the past year, and their biological children, especially for women. And then all index testing must meet the 5 C's, which we talked about earlier on. And then if an index client agrees to list down their partners and children, they should be contacted and informed that they've been exposed to HIV, and they should be offered a voluntary HIV, voluntary HIV testing services. The goal of index is actually to reduce the transmission of HIV by targeting, the population that have been exposed to HIV. Okay, so there is a difference between household testing and index testing. So in household testing, you go on in a household and and test everyone in the household of the index partner. So index testing is much more focused. We don't test everyone in the household. We just, focus on the members of, of the household that have been exposed to HIV by the index case. And then when we're reporting clients that have been tested on by indexing, we should not include clients that have been tested outside the target group. That is those ones that have not been exposed to HIV by the index client. So we focus on the sex partners and the drug-using partners, or the biological children of the index case, and especially the positive woman. So why should we offer index testing services? So there are a lot of advantages of offering HIV index testing, and on the client themselves, we provide support to people living with HIV to assist them in getting their partners and their children tested. And then the client, they have this sole responsibility of notifying, their healthcare providers of people that they think may have been exposed to HIV. And then with the partners and children, it minimizes, the notification of HIV exposure to the partners and the children of the index client. And then it allows the HIV exposed partners and children to actually be tested for HIV. And then on the community aspect, this is an effective way of, case finding, and it reduces any future rates of, transmission of HIV. Okay. Next slide. Okay, so this is just a slide to explain who the index client is in this case, and mostly of this it's in partner notification and not the children that are tested in index testing. So you can see that there is an index client right there at the far end, and then you can see the people that have been exposed to HIV through the index partners. So in this case, the number can be as close as to 21. So clients through an index test, an index case, if there are 3 direct partners, then those partners also still have no other partners, and it's cascaded in that way. So through an index client, we can actually be able to identify a lot more clients that are through index testing. The next slide, please. Okay, so this one just talks about, the sexual network linkages. So for this photo, I want to mention that these people that you're seeing here are not HIV positive. They're just here to illustrate what sexual networks are. So in case you identify anyone here, please, we are not identifying them as HIV positive or anything of that sort. So in a marriage, a traditional marriage, which we all know nowadays that in a traditional marriage, not a perfect way of saying that a married partner sticks to, their partners, in whether it's their husband or wife. So you can see the network that happens in a marriage. So there are these 2 people who come together, and behind them, there are these sexual networks. So again, here it's just a way of saying that through indexing or partner notification, we can actually identify more clients through indexing. Okay. The next slide. So we have what we call traditional partner testing approaches in index, testing and partner notification. So in traditional partner testing approaches, the client themselves takes the responsibility of disclosing their HIV status to their partner, and then they encourage their partner to actually seek HIV testing services. Then we have other innovative assisted HIV partner testing approaches. So we have one approach that is called the contract referral. So in the contract referral, the index client gets into a contract with either a counselor or a healthcare provider. In this case, the index agrees to disclose their HIV status to their partner and refers their partner for HIV testing services. If the partner does not come to the facility or access HIV testing services within the agreed period in the contract, then the counselors or providers will contact the partners directly to notify them that they may have been HIV exposed. And then the counselors have to maintain confidentiality in this case, and they do not have to disclose who the index client is. So there are other approaches. The next approach is the provider referral approach. So in the provider referral approach, of course, with consent of the HIV positive index client, the counselor or the provider would directly now contact the client's partner and informs them that they may have been exposed to HIV. And then they offer them a voluntary HTS while maintaining the confidentiality of the index client. Then there's also what is called the dual referral system. In this approach, a trained provider sits down with the index client and their partner or partners to provide the support as the client discloses his or her status to their partner or partners. And then the provider offers voluntary HTS services to the identified partners. So in all these approaches, what we're supposed to know, go to the next slide, please. Okay, so in all these approaches, the main important thing is to maintain confidentiality. So we all know that if at all we don't maintain confidentiality in index testing or partner notification, then we're not going to be successful in identifying the partners that we are trying to reach to. So confidentiality, as you know, is protection of personal information. It is the duty of whoever is cancelling or the providers of HTS services not to review the information of the index clients. So confidentiality is very key. So information about partners should actually never be conveyed back to the index client. So if we identify the index client, a provider, the partner of an index client, the provider or counselor is not supposed to go back to the index client to mention what the outcome was on the test for the partner. So at all levels, confidentiality has to actually be maintained. Next slide. Okay, the next slide. Okay, next slide, please. So how do you maintain confidentiality of patient information? So we have physically, a secured environment whereby all the information for the partner services that we're providing are locked in a filing cabinet. And then also have whereby we have electronic, we keep, the information in an electronic system, and the electronic system actually does also have a password. And then know that we can share the information within the facilities to provide optimal care. So this information should actually be kept confidential as well. So shared information is whereby maybe in a facility, an index client is interviewed to get the names of the partners. And then the facility shares the names of the partners with the community, organizations that do probably index testing services. So both people at the facility and the community must keep this information with high confidentiality. They should never at all share what the status is of the partners. So in this case, on this slide, I would like to look at two scenarios where we can see whether there is breach in confidentiality or not. So you have a client called Alice who names two partners, John and Isaac, and then you contact Isaac and he demands to know which of his partners gave his name. And then you say, by law, I'm not allowed to provide that information. So we see that in this case, the provider still keeps the information with high confidentiality. Then in the next scenario, you are counseling Thomas, who has just learned that he is HIV infected. Then Thomas has agreed to participate in partner notification services and names Sarah as a partner. Then you recognize Sarah's description and recall that she already has been tested for HIV. And you told the partner not to worry about his partner because they actually have already been taken care of. Okay, so in this way, confidentiality is not So in index testing, communication is very key to success of index testing. So we need to have these good, communication skills. We need to, use appropriate, non-verbal messages, use appropriate verbal messages, and, be effective listeners as healthcare providers, if at all index testing has to be successful. Next slide. Okay, so how do you communicate well with our clients? I'm sure you know how you're communicating well with our clients. So I hope we all welcome our clients in our clinics. And then by welcoming them, we probably may mention their names because then they feel, a personal touch, to the communication. So we encourage that you ask your clients to talk. If at all your clients are not talking, they may not provide you with the information that is required for indexing. And then when you are communicating with your clients, you have to listen to them, give them time to listen. And then when you're also communicating with your clients, you need to look at your clients so that they know that you're paying attention to them as well. If you do not have this time in the actual time that you have with your clients, you need to also be continuously be seen to be communicating with them. Okay. The next slide, please. Okay, so the following have to be considered when offering index testing. So we have to know that index testing services are not a one-time event, but should continually be offered. And then we need to introduce basic partner notification service concepts and benefits at pre-test counseling, and then counseling immediately after HIV diagnosis. And then index testing services have to be offered at least annually to our clients. And if at all a client comes in and says they have a new sexual partner, then indexing has to be done at that point. And then partner solicitation can be done by a trained HTS counselor, a nurse or a nursing assistant, a linkage coordinator, or a patient navigator. Or then individuals should receive training on how to conduct index testing, because if you don't know how to conduct indexing, then you will not do the right thing. Then the other things to consider are that with the concerns of stigma and to avoid breaching the confidentiality of the index client, we also need to consider offering HTS services to households around the index client's household when we go in the community. This is just to address the stigma issues. Then index testing should be extended to those we think are not engaging in sexual relationships. For example, adolescents, adult singles, the elderly that are married, and even those ones that are unmarried. Then when a partner tests HIV positive, he or she becomes a new index client, and the process has to start all over again from the beginning. So the take-home messages from this presentation is that we still have challenges in identifying the 30% on the first 90, and then we need additional testing modalities to close the gaps, and these are through index testing and partner notification services and HIV Soft Testing. So HIV Soft Testing is not for everyone. We need to target the populations that are met with our traditional HIV testing services. Distribution of HIV self-testing should also be focused to the target groups. And then index testing and partner notification services are to also be offered to the virally unsuppressed clients and not only the new clients. The importance of confidentiality at any visit should be maintained. And then also that we need to extend indexing services to adolescents, to the young girls, the unmarried, elderly, not also to limit those ones we think that are sexually active. I think this is my last slide. Thank you so much for listening.
Thank you very much, Dr. Simwenda, for that very detailed and insightful presentation. A number of things you've highlighted. HIV Soft Testing has the capacity to help us narrow the unmet gap, the 30% of the 95 that we're trying to target. And we have the opportunity to link those who are HIV negative to preventive services and those who are positive to ART services. We've heard about the people that we need to target with both index testing as well as HIV self-testing. I think we've also heard now that there's a difference between index testing and household testing, which I think oftentimes a number of us tend to confuse. So household testing, we're targeting all members of the household, but index testing, we're targeting those that have been exposed to HIV through the index case. So at this point, I will invite any questions, comments from the networks. We can maybe allow 2 or 3. Any burning questions or comments from the network? From the hub? Do we have any?
Comment.
So we have a comment from the hub. That's Mr. Pemu?
Yes, please.
Okay.
Yeah. I wanted to add that as we do index testing, it's important for us that before we begin to elicit for sexual contacts to the index, we must also assess whether the index has had prior intimate partner violence with any of those contacts. And in the event where this is most likely to happen, we should not proceed with contacting the contacts of the index, because we don't want to put the life of the index at risk. So that is very vital as we do index testing. Even as we continue interacting with the clients, we must also continue to assess whether intimate partner violence is happening or is occurring with our clients. Thank you very much.
So thank you very much, Mr. Nkwemu, for that. We have been told that as we are indexing clients, we also need to take note of those that have been victims of violence, be it gender-based violence or whatever form of violence, because this may actually be precipitated. So we have a question from Matero level 1. Matero, you can go ahead with your question.
Okay, my name is Brenda Chombe. I'm a lay counselor. My question is, in an event where you test those involved in homosexual and you want to protect your partner, and then you find that this partner is maybe having anal sex with minors, how can you go about it, or what can you do? Because if you go on testing, you need the consent of the parents of those minors that person is having sexual contact with. Thank you.
Thank you very much, Matero, for that question. I will ask the subject matter experts to comment. Do we have a comment from Dr. Simwenda? If not, we can have a comment from Dr. Sivi.
So I'll comment.
Okay, so go ahead, Dr. Simwenda.
Okay. Yeah, so I'll just comment and then Dr. Sivile can come in. So if at all you noted, we mentioned that when you identify, the content of the index client, and in this way, this is a very unique situation. You approach, this case scenario. So if you identify the contacts of that index in this homosexual setting, then you need to go in and test the target groups in a way that should not identify that you're actually going to those target groups, and in a way that the index client will actually be identified. So in a case that that these people, for example, is that from Matero, are found in this household, you go in as though you are testing household members, because you're trying to target clients that have been exposed to HIV. And in this case, it's a very sensitive matter. You still have to keep the confidentiality. So I think Dr. Sivile can also come.
Thank you.
Good afternoon. I think there are two sides to your question. The first side is that we know that being an MSM is not allowed according to the Zambian law. So do you report an MSM, or any other sort of key populations. This is female sex workers, transgenders, and the like that we usually deal with. I think the simple answer to that question is probably it's not in our interest as the HIV response program to report this, and this, in our experience, it does hamper our work. You know, we'll have sites where we have these safe spots where these people congregate, and once those report messages starts to, to come up, we find that they begin to resist our work, and this has been experienced. So in my opinion, obviously it's an issue that I'm not quoting anyone, but this is just from experience, is that in these peculiar populations, if you prioritize legal issues, it's not good for our response. So I wouldn't advise reporting to the authorities. I think that's a simple question a simple answer that I have. And I think we've had these experiences where you go into these places and they think we are the ones that actually reported to the authorities when it was someone else, and that has really disturbed our work. There's another side of the story of not just being a key population, is to, having sexual assault or having sexual relationships with minors. I think that becomes a different story altogether. I think the advice that I would give on that one is maybe you need to reassess the case. Even when you look at these minors, it becomes a bit of a different story altogether. Yeah, but remember that according to the lecture that we've heard today, confidentiality becomes also an issue. You are bound to keep the information that you have discreet. But maybe that, I don't know what other people think when you're dealing with a minor, someone is having sexual relationship with a minor, and during your work that comes up, maybe you might consider reporting that one. That's what I would think. Look, we have Dr. Muya, a pediatrician here. I would seek for his advice when.
Thank you, Dr. Seville. Dr. Muya, do you have a comment? The question raised.
Yes. For this one, for sure, it needs to be reported to police because he's abusing a minor. He's a pedophile. It needs to be sorted out.
Thank you very much, Dr. Muya, for that. So we have another question coming in from Kafio Estates Clinic.
Sorry, probably an additional comment. Okay. You shouldn't also forget the minor, because the minor has gone through traumatic experience there. And probably this minor should be referred to one of these child sexual abuse one-stop centers that we have around, so that the experts can help the minor also.
Thank you, David, for that comment. So we've taught that where we are dealing with a minor, obviously we also have to take the extra step to make sure that the minor is protected. So Kafio Estates Clinic, kindly go ahead with your question. Kafio Estates. Okay, Kafio Estates, if you are unable to, you can type your question. Do we have any other comments from the hub? Okay, one comment from Dr. Seville.
Yes, I just wanted to add on probably both index testing and self-testing. Index testing brings up a lot of excitement, especially to our community health workers or community health volunteers. But I want to remind everyone that when you're looking at index testing or all these network kind of testing, the interest is not to look at transmission networks. It's not, you're not looking at
Fine, how are you?
I think the same should apply. For instance, they cannot go and confront their partners because they have seen them in the database. That should be off limit. But otherwise, other than that, I don't know what we can do, because I mean they have those rights. We not stop, and they have to do their work anyway. But the key thing is that we have to remain professional and try to maintain professionalism as much as possible.
Okay, thank you very much, David, for that. We will be going to a case presentation shortly. Okay, before we do that, we'll ask David to make one last comment, and then we'll also relaunch the poll. So maybe David, just quickly make the comment. I know we have a lot of burning questions and comments, but hopefully we can get another session so that we continue the discussion on index testing and HIV self-testing. So David, make a quick comment and then we'll relaunch the poll.
Basically, it was on provider referral, where a provider takes it upon themselves to notify the index contact that actually they need a test. So what we have discovered is that it's very difficult to call somebody and tell them you've been exposed to HIV in our setup. And we have just decided not to do that, because you bring in a lot of questions. I mean, who exposed me? And going by what Dr. Sivira was talking about, I think it's in line. So what we do instead is to offer health services that are available in our facility to the contact, not necessarily focusing on the HIV testing.
Thank you very much, David. So at this point, I'm going to relaunch the poll and we can quickly vote, and then Dr. Simwenda can comment on the polling. So I will relaunch the poll just now. Okay, so we can quickly vote. The first one was the following statements are true about HIV self-testing except. So we have A, B, and C there. So after the didactic presentation, I'm sure we've learned a thing or two, so we can just quickly vote. So one facility so far. Okay, we have split answers between B and C, 75%. 8% think it's B, which is an HIV self-test result is not affected by the window period. So you're choosing the one that is not correct. Okay. Okay, I'll end the poll. And so 88% think B is wrong. So Dr. Simwenda, would you want to comment on the results? So this is how we voted. Dr. Simwenda, you can go ahead and comment.
In this case, the answer is actually B. Okay. The question was asking you for a statement that is incorrect, not correct, isn't it? I hope we all got that. So an HIV self-test is also affected by the window period. So if someone is in the window period, the HIV self-test may be negative. So the answer there was B. I've seen that there's some that went for the third answer, and I should emphasize that an HIV self-test is a screening test. According to the current algorithm that we have, if a client tests positive using an HIV self-test kit, they still have to go back to the facility to be tested again using the determine and then with the confirmatory SD bar. Thank you.
Okay, thank you very much, Dr. Simwenda. So I am relaunching the second polling question. And the question was, choose a statement which correctly describe what index testing is about. So we had 3 options there. So we can quickly just vote and Dr. Simwenda will comment and then we'll move on to our case presentation. So option A, an index client is a person who has had HIV exposure, regardless of the HIV status. B, in index testing, all household members and relatives of an HIV positive client are tested for HIV. And then we had C, which so far we have 100% of, for which we have 100% of the votes. And that the goal of index testing is to break the chain of HIV transmission by offering HTS to persons who have been exposed to HIV. So I'm going to end the poll and share the results, and this is how we voted. Dr. Simwenda, quickly, you can comment on that one. 95% think C, but we still have 5% who think B is the answer.
Okay. Yeah, so C there is, the right answer, and we know why we are doing index testing from the presentation, and then also from the data that has been presented. We really want to identify those ones that have been exposed to HIV and break the chain of HIV transmission. So for those that have gone for option B, in index testing, we're not targeting all household members and relatives of the index client. We are only targeting the clients that have been exposed to HIV by the index client.
Okay, thank you very much, Dr. Simwenda, for that. I hope we have at least learned something regarding HIV soft testing and index testing, and also the difference between index testing and household testing. So at this point, we are going to move on to our case presentation. Our presenter for today is from Sichili Health Center, and his name is Kelvin. Kelvin is a clinical officer, ART prescriber, and he'll be presenting a case about a baby, an infant that was identified through index testing. So Kelvin, you can go ahead with the presentation. Kelvin, are you able to hear us?
Yes.
Okay, you can go ahead with the presentation.
All right, thank you, and good afternoon, everyone. Our case today is, as she said, it's on the baby. On the baby, and the issue is as follows: an 11 years old baby, HIV exposed, a second breathing identified during follow-up of the mother with an suppressed.
Sorry, Kelvin, can you move close to the mic?
All right, thank you. Able to get me now?
Yes, we can. Go ahead.
All right. The issue is as follows. An 11-year-old baby, HIV, identified during follow-up of mother with an.
Okay, Kelvin, we're still having a bit of challenges getting you clearly. Perhaps Dr. Chipasha, are you able to assist us with the presentation? Dr. Chipasha?
Yes.
Okay. So we are requesting that you kindly assist us with the presentation. We're unable to get Kelvin clearly.
Okay. So the history is as follows. An 11-month-old baby was HIV exposed and was identified during follow-up of the mother with an unsuppressed viral load, and index testing was done that day. So the baby was recently diagnosed with trisomy 21 and just started to sit without support. He's currently still breastfeeding. However, mom would like to wean the baby off on 1st of April, 2019. DNA PCR, which was done at 9 months of age, was negative. And the HIV serology test was done on the day that the index testing was done, which is 6th of March, 2019, and it was negative. Next slide, please. The maternal history. Mom is a 46-year-old who was diagnosed with HIV 11 years ago and she started TLE 5 years ago. She was physically contacted on the 6th of March during the same follow-up due to unsuppressed viral load. And currently she's being treated for disseminated TB and PID, and also being evaluated for ART treatment failure. She hasn't had any prior medical admissions, no TB contacts, and no personal history of TB. Next slide. This is the summary of the drugs. For mom, she was on TLE from the 8th of January 2014 to 12th July 2016. Then she was switched in 2016 because at that time the facility where she was being attended to did not have TLE. And so she took the nevirapine-based regime till 7th of March 2019, when she was put back on TLE. And the reason for that is the clinical diagnosis of the tuberculosis, and also to reduce the pill burden. She was put on 4 FDCs, 3 tablets, OD, on the 7th of March 2019, based on the clinical findings. And she was also put on metronidazole, doxycycline, ciprofloxacin on the 7th of March 2019, because during examination, she was noted to have cervical motion tenderness and a yellow vaginal discharge, as well as bleeding post visual inspection with acetic acid. And for the baby, the results of the VIA were negative. The baby's drug history, this baby has never received prophylaxis, currently not on medication. He's still breastfeeding and was also diagnosed with infantile malnutrition. Next slide. For the examination, the baby is small for age, has a flat nasal bridge, low set ears, and epicanthal folds. He was also noted to have a Sandow gap. The other findings were essentially normal. The heart sounds were normal, and the chest was clear. The MOH was 11.7 centimeters, weight 6.7 kgs, the length was 27 inches, and the weight for age was below the 3rd percentile. Next slide. Examination of the mother. She's chronically ill-looking and wasted. There was no pallor, jaundice, or jaundice noted. She was a febrile at the time of examination with generalized lymphadenopathy, and most of the lymph nodes were matted. For the vitals, BP was 124/79, temperature 36, heart rate 89, and her weight was 45 kgs. Her BMI is 16. Respiratory system, we could hear some creps on the left upper zone of the chest. And CVS, S1 and S2 were normal. On the abdominal examination, we found mild ascites with distended abdominal veins. There was no liver, spleen, or any other masses. Vaginal examination revealed, on speculum examination, we found an inflamed cervix with ulcers noted. And there was a very tender bimanual examination. Next slide. So for the results, I don't know if I should read all of them out, but anyway. So from 2010, the CD4 count was 684, creatinine was 55.9, ALT was 31.3, HB 9.8. In December 2010, CD4 count was 665, creatinine was also done and was 53.8, ALT was 182. HB was 11.5. In 2011, August, the CD4 count was 373. The other labs were not done. In November, CD4 count, November 2012, CD4 count was 460. The other labs were not done as well. In April of 2013, CD4 count was 394, creatinine 67.35, ALT 45. January of 2014, CD4 count was 103, and in June 2015, the CD4 count was 459. I must add that there was a hepatitis diagnosis which was made in 2015, but no results have been found and no notes really were attached to this diagnosis. We do not know the basis of that diagnosis of hepatitis. And I'm mentioning that now because we decided to order hepatitis B surface antigen based on that vague history. And as of today, it's positive. In February 2016, the CD4 count was 415 and creatinine 90.53. January 2017, CD4 count was 86, the creatinine 72.05, ALT 23.6. In May 2017, CD4 count was 153, and in February 2018, it did CD4 count and it was 104. The viral load was done for the first time and it was 5,690. Creatinine was 90.76. In March 2019, Gene Expert was done and there was no MTB detected. Gastric lavage was also done on the baby and no MTB was found. As of today, the HB for mom is 8.9. And as I said earlier, hepatitis B surface antigen is positive. Next slide.
Go on, Dr. Chipasha, so we can see the questions.
So our questions based on what is the best management for the kids? And
can you get us, Dr. Chipasha? Okay, we seem to be having a bit of a challenge with network.
We need some advice.
Okay, they're gone. Okay, so we seem to have lost Dr. Chipasha and the team there. So in summary,
How we can manage the matter in view of the diagnosis. Thank you.
okay, thank you, Dr. Chipasha. So I think briefly, in summary, we have an 11-month-old baby who is HIV exposed, was diagnosed during a follow-up of the mother with an unsuppressed viral load. That was on the 16th of March this year. And of note is that this baby, they had 2 tests done. A DNA PCR at the age of 9 months, which was negative, and a rapid HIV serology test, which was done on the day that they went to follow up the mother, which was also negative. The mother seems to be acutely ill, currently on TB treatment and not suppressed virologically. Her CD4 count has been below 200 since January 2017. So they have a few questions. And the first one is, how do you manage the baby? But I think before we get to the questions, maybe quickly from the network, do we have any clarifications, questions for Dr. Chipasha and the team regarding the case they have presented?
Yes, we have some questions.
Okay, so we have a question here from the hub. You can go ahead, Dr. Moya.
Yes, number 1, the length of the child is in inches. They're not supposed to be inches, use inches this time. Number 2, they haven't told us the sex of the child. Then the family history, we don't know the order of birth of this child. Is the firstborn, whatever. So we need to have all that information so that we can advise accordingly.
I would add we need the marital status as well, and if she had, and her sexual history.
All right. So, Dr. Chipasha, we have a few questions here from the hub. Are you able to get us?
Yes, I can get you.
Okay.
So my apologies for the length in inches. Yes, it was supposed to be changed. I think it was one of the last minute things that were put, but unfortunately we didn't. 27 inches was translating to about 67 centimeters. And our baby is a male, and he is the 7th child born to a couple who have 4 other children together. Okay, so the mother has 7 children in total. The first 3 children were from different men in the past who she said she was not married to. This is her first marriage, and she has 4 children, including the baby, with the current husband.
Okay, thank you very much. And about the husband's status, do we have any information regarding that?
So the husband is RVD reactive as well. He is
Hello, Dr. Chipasha. Okay, I think we'll clarify later. It looks like
actually, and the last viral load was done in November. I can get.
Hello, Dr. Chipasha. Okay, I think we'll get some clarification later. So do we have any other questions, maybe? Okay. Okay, so we have a response from Dr. Chipasha saying the husband is HIV positive. And then we have a few questions. Yes. Do we have any questions from the hub?
The father on drugs, sort of, ART.
Yes, she said the father is on ART. First line.
Which?
Okay, so do we have any comments?
But our current viral load. The last one was done a year ago.
Yes, so the last viral load done in May, that was the latest viral load that they had. So I think the other details is that the patient was followed up on the 6th of March based on that viral load, and that's when they found that she was actually very acutely ill. So the viral load for the husband done 2018 September, that's additional information, was 15,000 copies per mil. And they're saying he's on TLE since 2019. I'm not so sure if this viral load was done before he was commenced on ART or after. I hope Dr. Chipasha will be able to confirm that later. So maybe Dr. Muya, any comments? They have a question regarding the management of the baby?
Yeah, we want you to start first, the adults. How do you manage this mother? Then we come in.
Okay. So it has been thrown back to us. How do we manage the mother? So maybe before we get to the hub, do we have any contributions from the network, how we can manage the mother? Chipata? Macha. Okay. So Chipata, maybe do you have a comment on the management of the mother before we go to Macha? Okay, Macha, your hand is up. Macha Mission, you can go ahead with your questions or contribution. Macha, you can go ahead with your question.
No. The first question was on the indexing. Then we'll come back to the question of this case. The question on the indexing is, we have a patient, we tested positive, and she's a woman. Now, this patient, she's not ready to come for treatment, but she's going out with other men. Now, the question is, what can we do with such a client?
Okay, thank you, Macha, for that question.
Because this person has.
Okay, thank you for that question. We'll tackle it later, perhaps when we come to talk about the adults. But first of all, I wanted to tackle the current case that has been presented, where we're talking about the child that was identified through indexing. Do you have any comments to that? So we've taken note of your question, and hopefully we'll bring it up for discussion. Do you have any comments regarding the case that has been presented today?
Yeah, on the case, we are wondering because the last viral load, which was in May, which was 20,930 to up to date, we are just asking ourselves to say, why is this mother not yet on second line? That's because from that time, having the 2 viral loads, I think this woman was supposed to be on second line even by this time. So that was our question. So why is she not yet on second line?
Okay, so Dr. Chipasha, we have a question here for your team. Seeing that the viral load that we have is from May 2018 and it was already above 20,000 copies per mil, why isn't the patient on second line? Are you able to respond to that, Dr. Chipasha? You can unmute Dr. Chipasha. So
Can you get me?
Yes, we can get you clearly.
So thank you for that question. Actually, it was a very big learning point as the facility at Sichili. After finding what was going on with our patient, she's just one of the many other cases of unsuppressed patients who are not being followed up or managed appropriately. So that's probably the reason why no intervention was put in place after receipt of the viral load in May 2018. We have not been conducting enhanced adherence counseling sessions for these patients. We have not been indexing, following up contacts or anything like that. So she is just one of the other patients. And I think we learned from that as a facility.
Okay, thank you very much. So Macha, you had the response? So they had not been doing that. They had not been following up patients with unsuppressed viral load, and they had not been indexing clients. So it was a learning point for them. Okay. So we have one other question, Dr. Chipasha. They want to find out, the network wants to find out why the child was not put on cotrimoxazole. Do you have any comments to that effect? Dr. Chipasha? Can I mute Dr. Chipasha? Hello, Dr. Chipasha, can you get us? Okay, I think perhaps for now they'll be able to respond later. So maybe we can have comments
on that one. Yes, I can get you.
Okay, so you can go ahead. They want to know why child was not on prophylaxis, cotrimoxazole, and as well as ART prophylaxis.
Can you get me?
Okay, maybe you can type your response. Okay, we seem to have lost them. So I guess from the hub, I know Dr. Muya wants us to start with the adult. Okay. So Dr. Sivile, you can respond.
Yes, from the adult side, as I think the other callers pointed out, this patient has clearly clinical, immunological, and virological failure. And this patient should move to second line. The question is what sort of second line we should give this patient. There are several things to bear in mind. The first thing is the patient has got hepatitis B surface antigen positive. Then there's also this issue that the patient is still breastfeeding and they might be need to drop the viral load quickly. Yeah, so the probably propose, what I would propose as a second line regimen to this patient would be probably you put the patient on TLD and add another dolutegravir if you have it, and AZT. So AZT and TLD will probably do the work. If you don't have dolutegravir, then this patient can be put on AZT, lopinavir, ritonavir. You double the dose. Bear in mind that the patient is on TB treatment as well, yeah, and you have to continue with Truvada, to cover the hepatitis B. So probably that's a short answer for how to manage this mother. There are other things still not convincing. The diagnosis of TB. This patient has got lymph nodes all over. If it's possible, I'm wondering, can a biopsy do because the sputums are negative? Just remember that the gene expert is quite sensitive. If you find the gene expert negative, it's a reason to start looking for other things. You can get some tissue and take it to the lab. Viral load, obviously, to be nice to have a new viral load on file. Yeah, and yeah, other just supportive care will be applicable. But that would be my submission to how the mother should be managed. So the mother has got immunological, clinical, and virological treatment failure. Obviously, we need to handle the counseling issues. Why did this patient fail? I can appreciate that she's been on treatment for over 10 years. So probably it's just longevity of the therapy, but you need to go into social issues as well. Why have they been taking their drugs, adherence counseling, and things like that? Thank you very much.
Okay, thank you very much for that contribution from Dr. Sivile. May I just quickly get comments from Dr. Muya on management of the baby, and then we can summarize the recommendations. Dr. Muya.
Okay, no, Dr. Thomas.
Okay, and Dr. Thomas. Yeah. So Dr. Thomas, you can go ahead and maybe comment on the management of this baby.
Yeah.
What are your recommendations?
I think as far as the last test, the baby is just an exposed baby. So we can start the baby back on the prophylaxis with all the 3 drugs, but do a PCR because it was done 2 months ago. In case if the PCR comes positive, the baby should be changed to treatment because the drugs are different. Then, of course, as we said, the baby should be on Septrin. And also the mother is with the disseminated TB, so the baby should be on INH prophylaxis. And also this baby is with the Down syndrome. Then maybe we have to counsel the mother about future pregnancies and issues. And also for the baby, the feeding counseling, because the baby is with the moderate malnutrition. I think those are the things which we have to take care. And again, the prophylaxis period, since this is a high-risk baby, it should be for 12 weeks. But the mother wants to stop breastfeeding by 1st April. I don't know what's the criteria. Has she got enough other feeding option to have the baby a proper, balanced, nutritious food? If not, it's advisable to continue the breastfeeding. But then again, the condition of the mother is very ill. BMI is only 16. Has she got enough breast milk? All these things have to be considered, I think.
Okay, thank you very much, Dr. Thomas. Before I summarize the recommendations that we have made, or that we have received, rather, from our subject matter experts, we had a response from Dr. Shpasha regarding why the child was not on prophylaxis. So the mother delivered from a health facility, another health center. It must be a health post actually. And we are not so sure about the antenatal records of the mother. So they're not really sure why the baby did not receive any prophylaxis because they could not get any records. So I think Dr. Shpasha and the team, it would be nice if you made a follow-up and maybe update us on what happened antenatally and how this baby was made. So with regards to the recommendations, in summary, we've heard from the subject matter experts, starting with the mother. The mother is critically ill and she seems to be failing therapy, immunologically, clinically, and biologically. So the recommendations have been that you get a viral load, you get a lymph node biopsy as well, and possibly consider switching this mother to second-line ART. And you have options for the second-line ART because we do not want to leave out hepatitis B, and we know that the patient is also on rifampicin. And in that regard, our options are to give the patient TLD, which is tenofovir lamivudine dolutegravir, with a standalone dolutegravir, 50 milligrams, if you are able to source it. Of course, the tenofovir will cover for the hepatitis B. And this patient, we expect that she should be able to suppress. And the other options we've been given include zidovudine with tenofovir, lamivudine, and lopinavir, but you have to double dose the lopinavir. So we hope those recommendations have been helpful. Do we have any comment from you, Dr. Chipasha? Dr. Chipasha, are you able to get us? Okay, we seem to have lost communication. So for the child, for the rest of the network, the recommendation is that we get a DNA PCR so that if the child is actually confirmed HIV positive at this point, you know the mother is not virus suppressed, so there's still a risk, then the child has to be on ART. Yes, we can get you, Dr. Chipasha. We seem to have lost you for a bit, so we're just reading out the recommendations, the summary for the child, that we need to put the child on ART prophylaxis, cotrimoxazole, as well as INH prophylaxis, and get a DNA PCR as soon as possible so that when we confirm the HIV diagnosis in the child, if the child is infected, we put the child on a full ART. And for the mother, we have a number of options that you could substitute. That is switching her to second line. And I think we'll be able to send this to you by email so that at least you'll be able to get the full summary of how we can manage the patient. But for now, do we have any comments regarding the discussion of the case? Do you feel you have been helped? Okay, I think we have lost her again.
Sorry, Dr. Sivile.
Okay.
I have a question also.
So I think we are going to get one more comment from the hub and then we'll wrap up. So Esnat, so we'll get one more comment from the hub.
So, sorry, it's not a comment, it's a question regarding the second line for the mother who has also hepatitis B. We don't have standalone AZT and standalone TDF. That's where the challenge is. So maybe an alternative, if we don't have standalone TDF and AZT, what is the alternative second line?
Okay, Dr. Sivile, maybe you can respond quickly on that one in the event that we don't have a standalone tenofovir to cover for the hepatitis B.
Okay, yeah, that gets to be a huge challenge we are facing. Dr. Mpeta wants to answer.
I think we had tackled the similar case last time, and we agreed that then it will mean that in this case, since we don't have any options and the issues of toxicity, if we were to increase the dosage for lamivudine, we would rather keep on the dosage that is in Combivir, AZT, and 3TC, and we treat the hepatitis B with monotherapy. The issue of resistance does not normally develop within the first 2 years, and we hope that by that time, probably the HIV could have been controlled, and then we could find alternatives. So for now, just the Combivir, the lamivudine in the Combivir will be able to take care of the hepatitis B, rather than if we were to give 600 lamivudine that is coming from TDF and that coming from AZT. So just giving AZT would be important, would be enough, rather than adding on to VADA, which will come with VTC.
Okay, thank you very much, Dr. Mpeta, for that comment. I want to thank all the participants for joining in and for your contributions, actively participating. It's been an interesting discussion, starting with the index testing, self-testing, and now the case that has been presented. And I hope that we have learned one or two things, and we hope to see you joining in at each echo session as we continue to share experiences and be able to share knowledge. So for next week, our topic will be on reaching men, and the presenter will be Dr. Ahmed Sagami, and the facilitator will be Dr. Mteta. So I hand over to Nomsa for any announcements. So we have no announcements for today, so just make sure you fill in the registers so you can end those CPD points. So thank you very much. We are ending the meeting now. Hope to see you next week. Bye-bye.